10 minutes late. వస్తున్నా చూస్తారా సార్? Good morning everybody. Today we are going to discuss regarding Monteggia fracture dislocation. Monteggia fracture dislocation. So I will be discussing the topic under following headings: 1. Definition. 2. History, epidemiology, classification, mechanism of injury, clinical features, management, complications, old neglected Monteggia, and recent updates. Sir, historically, Monteggia fracture dislocation is described as fracture proximal third of shaft of ulna with dislocation of radial head. In 1814, Giovanni Battista Monteggia, surgical pathologist and public health official in Milan, Italy, first described Monteggia fractures. He observed the original 2 injuries in cadavers and provided the description traumatic lesion distinguished by fracture of the proximal third ulna, anterior dislocation of the proximal epiphysis of radius. So epidemiology, Monteggia fractures constitute around 1 to 2% of forearm fractures. Of the Monteggia fractures, Bado type 1 is the most common, accounting for 59%, followed by type 3 26%, type 2 5%, type 4 1%. Classification of Monteggia. Bado's classification. Jose Luis Bado in 1958 divided Monteggia fractures into 4 types. Bado classified certain injuries as Monteggia equivalents because of their similar mechanism of injury, their radiographic pattern, X-ray pattern, and method of treatment. So type 1 is anterior dislocation. The radial head is dislocated anteriorly and there is an anterior angulation of the ulna fracture in the diaphyseal or proximal metaphyseal area. Type 2, it is posterior dislocation of the radial head with posterior angulation of the fracture of ulna. Type 3 is lateral dislocation of the radial head with lateral angulation. Type 4, it is any dislocation of the radial head with additional radius shaft fracture. Any of type 1, type 2, type 3 injuries with additional radius shaft fracture is type 4. Here you can see this is type 1 because there is anterior dislocation, anterior angulation. Type 2, posterior dislocation, posterior angulation. Type 3, lateral dislocation, lateral angulation. Type 4, any dislocation, fracture anywhere in the ulna with extra fracture in the radial shaft. It is type 4. So type 1 equivalents are isolated anterior radial head dislocation, ulnar fracture with fracture of the radial neck. So why it is called equivalent? Because of their mechanism of injury and their X-ray pattern and similar method of treatment as Monteggia fracture. We classify these fractures as Monteggia equivalents. So 1, it is isolated radial head dislocation. 2, ulnar fracture with fracture radial neck. 3, isolated radial neck fracture. 4, fracture of ulna diaphysis with olecranon fracture with posterior dislocation of ulnohumeral joint with or without fracture of proximal radius. So these are Monteggia equivalents. Monteggia equivalents: 1, isolated dislocation of the radial head. 2, ulnar fracture with radial neck fracture. 3, isolated radial neck fracture. 4, ulnar diaphysis fracture with olecranon fracture, dislocation of the elbow ulnohumeral joint with or without fracture of the proximal radius. Type 2 equivalents are, in the original classification, Badow stated that there were no equivalents to type 2 other than epiphyseal fracture of radial head. The posterior elbow dislocation can be considered as type 2 equivalent. So type 2 equivalent in children. Type 2 is posterior dislocation of the radial head with posterior angulation. It is Badow type 2 Montesia. Posterior elbow dislocation can be considered equivalent to Badow type 2 Montesia. X-ray evaluation, AP and lateral X-rays of the forearm. X-ray of the joints of either end of forearm, particularly the position of the radial head. Radiocapitellar relation. As you know, the radial head articulates with the capitellum of the distal humerus, and the proximal ulna articulates with the trochlea of the distal humerus. So what is the relation between the radius and the capitellum? It is best defined in the true lateral view of the elbow. A line drawn along the long axis of the radius bisects the capitellum. Okay, here you can see. So this is the humerus, this is the capitellum, this is the radius, and this is the ulna. Okay, so anywhere in any range of motion, if you draw a long axis along the long axis of the radius, this should bisect the capitellum. This should bisect the capitellum. One more thing is, line drawn along the anterior shaft and posterior shaft of the radius should enclose the capitellum. Okay. Management, non-operative reduction of the ulnar fracture. To re-establish the length of the ulna by longitudinal traction, manual correction, any angular deformities. Up to 10 degree of angulation is acceptable in a complete fracture. Reduction of the radial head by flexing the elbow to 90 degrees or more. Flexion of the elbow to 110 degree to 120 degree stabilizes the reduction. And then immobilization. Here you can see, by longitudinal traction you are distracting the fracture fragments. Then supination, we supinate so that the radius falls into place, and then flexion to 90 to 100 degree, and then immobilization in 100 to 110 degree supination. 100 to 110 degree supination. Okay. So type 2 Montesia fracture dislocations more common in older patients, approximately 13 older patients who have sustained significant trauma. 5% of most series of Montesia in children. Clinical findings: elbow region is swollen. It exhibits posterior angulation of proximal forearm. Posterolateral to normal location of the radial head, the entire upper extremity should be examined because of the frequency of associated fractures. Treatment, non-operative. Ulnar fracture is reduced by longitudinal traction on long axis of the forearm while the elbow is held in 60 degree of flexion. Radial head may reduce spontaneously. Here you can see, by longitudinal traction you are reducing the elbow. By longitudinal traction the radial head is reduced, radiocapitellar joint is reduced, and then immobilization in 60 degree flexion. Type 3 Montesia is a lateral. Clinical findings: lateral swelling, varus deformity of the elbow, and significant limitation of motion. Second in frequency to anterior type 1 Montesia fracture dislocation. More chances of radial nerve injury and posterior interosseous nerve injury. Deep branch of radial nerve injury. Next, open reduction of the radial head may be necessary because of interposition of soft tissue between it and the ulna. Radial head may be displaced laterally or anterolaterally. Ulnar fracture is in the metaphysis. Radial angulations of the fracture is common. X-ray of the entire forearm needs to be taken because of the association of distal radial ulnar fractures with this type of elbow injury. Non-operative elbow is held in extension, longitudinal traction, valgus stress. Radial head may spontaneously reduce. Ulnar length and alignment must be maintained. To ensure a stable radial head, ulnar length should be maintained. Here you can see by longitudinal traction and slight valgus stress. Here you can see the radial head is reduced. Maintenance of reduction is by means of long arm cast with elbow in flexion. Degree of flexion varies the degree of radial head dislocation. Here you can see the elbow is extended, abducted, and pressure over the radial head, supination and flexion. So type 4 lesions are relatively rare. More swelling and pain may be present because of the degree of force which is required to create this type of complex injury. Particular attention needs to be taken for neurovascular status, anticipating the possible increased risk of the compartment syndrome. Treatment: close reduction can be attempted, but mostly it's an open reduction and internal fixation. So radial angulation, flexion 80 to 100 degree, then immobilization in 100 degree to 110 degree, and supination. Operative treatment: Monteggia fractures are a fracture of necessity. Most of the Monteggia fractures need to be surgically fixed. But a trial of non-operative treatment can be done in children. So what are the indications for operative treatment? 1. Failure of ulnar reduction, failure of radial head reduction. So if the ulnar fracture cannot be reduced in satisfactory alignment, by closed treatment, operative intervention is indicated. Intramedullary fixation rather than fixation of the plate is standard. Can also be fixed percutaneously by means of image intensifier and flexible nails and K-wires. In some patients, ulna can be fixed with a plate, and to maintain reduction of the radiocapitellar joint, K-wire can be used. So more common failure of reduction of radial head, more common in type 3 Monteggia because of interposition of soft tissue, a ruptured orbicular ligament and capsule, entrapped orbicular ligament pulled over the radial head. Surgical approach is Kocher's approach, Kocher's J approach. It employs an interneural plane between the anconeus and extensa carpi ulnaris. Anconeus is supplied by the radial nerve, extensa carpi ulnaris is supplied by the ulnar nerve. So internervous plane is between these two muscles. This approach protects the posterior interosseous nerve. So next approach is the Boyd's approach. So if the reduction is unstable, reconstruction of the annular ligament should be done. It can be done by means of the fascia lata. Fascia lata can be taken to reconstruct the annular ligament. Okay. See, here you can see the ulna is fixed by means of a plate. See, after fixation of the ulna by means of a plate, we check for radial head, radiocapitellar joint stability. If the radiocapitellar is still unstable, then we need to fix the radiocapitellar joint by means of a K-wire. Complications: neglected Montegia, nerve injuries, periarticular ossification or myositis ossificans, and compartment syndrome. Old undetected fracture dislocations. Reduction of dislocated radial head at time of injury can prevent difficult problem, persistent radial head dislocation. Annular ligament reconstruction can be done by means of triceps tendon, transcapitular pin for stability, and also fascial atta can be done. The central slip of triceps is used to reconstruct the annular ligament. Central slip of triceps. Then osteotomy. Various types of osteotomy have been used to facilitate the reduction of the radial head. Kalamchi procedure, a drill hole ulnar osteotomy to obtain reduction of the radial head. Mehta osteotomy of the proximal ulna stabilized with bone graft. So if the radial head is difficult to reduce, then we do a ulnar osteotomy, distract it, and do a bone graft here. Nerve injuries, 10 to 20% incidence of radial nerve injury, most commonly associated with type 1, type 3 injuries. Posterior intraosseous nerve most commonly injured. Nerve function usually returns by approximately 9 weeks after reduction. Median nerve, ulnar nerve injury, though uncommon, but have been reported in some cases. Periarticular ossification during Montegia, after Montegia fractures have been noted by X-ray around the radial head and also in front of the elbow, which is called myositis ossificans. Here you can see the ossification here. Here you can see this is the ossification. May occur in the area of the annular ligament also. See, here you can see the ossification here. This is the ossification here. This is the radius. This is the radius epiphysis, and this is the heterotopic ossification or a new bone which is formed. Other form of ossification is true myositis ossificans, which occurs approximately 3% of the elbow injuries and 7% of Montegia lesions in children. Myositis ossificans has good prognosis in patients younger than 15 years, appearing in 3 to 4 weeks after injury and resolving 6 to 8 months. Outcome of radial head preserving operations in missed Montegia fractures. There is a surgery which is called Hirayama's osteotomy, which is inherently more stable than the simple transverse osteotomy and should be combined with annular ligament reconstruction using a palmaris longus graft. So neglected Montegia fracture can also be treated by means of ulnar lengthening by means of Ilizaro technique. Reconstruction of radiocapitellar joint is easier using external fixation, since accurate correction of the ulna can be determined empirically. Thank you.